live demonstration of the surgery. I'd like to crack on with the next session. So I'd like to welcome our chairperson for the next session. If I hope all are here, Dr. S.N. Saraf sir, please come on the stage. Dr. Vikram Manskar sir, please come on the stage to moderate this session. Dr. Mahesh Prasad, Mahesh was he's here as well, and Dr. Abhishek, if you can kindly come up on the stage to moderate as well. Abhishek, you as well, yes. And the session we have 4 talks, 2 by Dr. Yash Gulati sir. Indication of for Oxford partial knee replacement is the first one, so I'll like to call upon Dr. Yash Gulati sir. And okay, please load on his presentation. Thank you. Sir has the next talk followed by the first one is that surgical technique for Oxford, partial knee replacement tips and tricks, and he's combined both the talks. So for moderators of the session, so he will be taking both the talks, so time has to be managed accordingly. Okay, thank you, sir.
Thank you, dear.
It's working. Hello. Good morning to you all. I, Dr. S.N. Saraf, along with my colleagues, Dr. Vikram and Mahesh Prasad, are welcoming to you all. Friends, Oxford partial knee replacement system is an excellent system because it is a mobile bearing and relatively it is a bone conservative surgery. So I'm inviting Dr. Yash Gulati for his presentation. Dr. Gulati, thank you.
I think, good morning. Thank you very much, Ashish, for inviting me here. I've always felt that I need to grow in height because now my face is being cut by the computer. So I have been asked to speak on mobile partial knee arthroplasty, something I passionately believe in and something I think is the way to go. And so I've combined both the talks. First is indications and why we do partial knee, and the other is surgical technique. Those who don't do it might find it a little too much to go into the surgical technique, but I'll go through the main points of the technique anyway, because I'm sure you will be taking it up sooner or later. So let's see this scenario 1. There is a medial arthritis, there is bone-on-bone arthritis, and is this the same scenario as, for example, this? So should these two be treated similarly, or should we have different strategies, as they say, horses for courses? In fact, now in 2016, a newer classification was brought in by Parvezi and his colleague, the new classification of Barris. So in this, I will not go into the details. I will request you to go through this paper in Journal of Arthroplasty 2016. But suffices to say that there is one absolutely separate entity known as anteromedial osteoarthrosis of the knee. So we need to recognize that, and we need to separate it from global OA or from posteromedial OA. So this is a different entity in itself. So what are the hallmarks of this entity is that this is a correctable anteromedial arthritis. The anterior cruciate ligament is intact and the lateral compartment is okay. So it's basically the medial arthritis. It starts with the anteromedial part and the posterior cartilage is intact. And many a time you'll find when you make the cuts, you find that this portion of the cartilage behind is actually intact. And this is an important bump, as we'll see in the next couple of slides. And this is anteromedial defect, and that's what anteromedial osteoarthrosis is. Now, in anteromedial OA, when we see this we talked about this bump. The medial collateral ligament is lax. It will contract if it is left in this position for years. But if we intermittently stretch it, then it will not contract. And that is what is important, that in anteromedial OA, the medial collateral ligament is actually not contracted. Why does it not contract? Because when we flex the knee, this femur rides over the bump here, and it stretches this lax ligament into its normal length. So that means it retains its normal length, and that is what is important. As a matter of fact, just as in valgus deformities, when we flex the knee, the valgus deformity disappears. In this type of varus deformity also, the deformity disappears when the knee is flexed, precisely for this reason. Now, if the anterior cruciate ligament is ruptured, then there is a wear and tear of this posterior bump. No longer can it ride on that, and then gradually the medial collateral ligament starts to contract and it becomes permanently contracted. Now, that is a stage which will lead to ultimately global OA, and that's a different entity. So anteromedial OA can progress into global OA if it is left for too long. So this is how it will turn into a fixed deformity. Even in extreme cases, this picture is from the book, this is not my picture. Even in extreme cases, sometimes it may actually be anteromedial OA and other compartments may be intact. So in a horrible looking, sometimes deformity, it may still be anteromedial OA. So in anteromedial OA, the bone, there is bone on bone contact. Remember, when it is not bone on bone, this is not an indication for the mobile partial knee arthroplasty. We can discuss that, why not. Anterior cruciate ligament and medial collateral ligament are functionally normal. This word functionally is very important because many a time you'll find that anterior cruciate ligament on inspection does not look normal, but it is functionally okay. And the lateral compartment has full thickness cartilage. These are important. So we need to demonstrate bone on bone medial OA. Sometimes you may not find medial bone on bone when you do a standing X-ray, then you do a single leg standing X-ray. And if patient is symptomatic enough and you think it is anteromedial OA, you can even do a varus stress view, and if you can demonstrate bone on bone, then again that is an indication for Oxford knee or a mobile partial knee. And then we do, and one more important point is to demonstrate whether the anterior cruciate ligament is intact or not, or whether it is anteromedial OA. We don't need MRI. We do not need arthroscopy to see whether anterior cruciate ligament is intact. In fact, they are misleading because sometimes you see fraying in MRI. More often than not, they will always report partial tear. Even in normal people who have no symptom, the report will be edema, mucoid degeneration, partial tear away. So these are all confusing. So all you need is a good lateral X-ray, and if the defect is not reaching all the way back, then it is anteromedial OA. Otherwise, if it has reached all the way back, then it has gone beyond that stage. That is all that is required to see preoperatively, and this is a very important slide, and we need to make sure that we understand this. As a matter of fact, before I started doing partial knee, for almost a year, we would write on the board that this is what we expect. After clinical and radiological examination, we used to utter and say loudly, we expect that this is what the kind of knee we will find inside. And for a year we did that exercise, and when we were more than 95% correct, and that's the stage we started to take up the Oxford knee or a mobile partial knee arthroplasty. So in valgus, the lateral joint space should not collapse, the medial joint should open, showing that the medial collateral ligament is not contracted. That is showing the full thickness cartilage laterally. And again, it's very important to how to take the X-rays. In my own hospital in Apollo, Delhi, till today, I many a time go personally to do these X-rays. I've trained the radiographers because if these X-rays are not right, again the results will not be right. So the X-ray tube has to be tilted 15 degrees, there has to be a wedge underneath, the patella should be central, and all these things we have to see in stress X-rays, because when we are doing stress X-rays, many a time the limb will get rotated and then it will give wrong information. So this is again very important. And then we look at the patellofemoral joint. If there is medial patellofemoral OA, that's fine, we accept it and go ahead with the partial knee. If there is significant lateral patellofemoral OA, then we would not do a Oxford knee, because that is not. Again, in inflammatory type of arthropathy, we would not do partial knee, because obviously it's a global pathology and there's no point doing this. So to summarize, if there is full thickness medial cartilage loss, functionally normal anterior cruciate ligament, functionally normal medial collateral ligament, full thickness cartilage in the lateral compartment, then we are game to go ahead with Oxford partial knee. And as we will talk later, age, weight, etc. now do not matter. Although previously there were a lot of contraindication, but not anymore, because the results are good. A couple of differences between partial knee and total knee. If there is a fixed flexion deformity of 10 to 15 degrees, we can still proceed with partial knee, and this will correct later on, because we are not releasing the structures. These will stretch. Whereas in total knee replacement, since we have released these structures, whatever we get on the table will be the final result. But that's not so in the case of partial knee. Similarly, in total knee replacement, we are dividing so many ligaments, releasing so many structures, whereas in partial knee, if we happen to release the medial collateral ligament accidentally, the surgery has to be abandoned and we need to go to a total knee arthroplasty. So it's a very fine balancing, very sophisticated, tissue sparing, very little surgical trauma kind of a surgery, because the amount of bone that is also removed is less than the size of a biscuit. So these are, obviously that's why the results are better. Again, whereas in total knee, we are so obsessed about the alignment. We saw Robert, I personally use computer navigation. We are so obsessed that it should be within 3 degrees of mechanical axis. In this partial knee, especially in mobile, it doesn't matter. You can go 10 degrees one side or the other. It's part of a sphere. It will just compensate. It will just not matter. So these are, and our alignment in partial knee does not depend on the cut. It depends on the thickness of the bearing. So these are very fundamental differences between partial and total knee arthroplasty. Our goal in partial knee arthroplasty is remove as little of tibia as possible, because we want to place this plate on the solid part of tibia. The deeper you go, the higher are the chances of having either intraoperative or postoperative tibial plateau fracture. Now that is extremely important. Never ever recut tibia. If you have to cut a bit more, if it is tight, we can take away a little bit more of a posterior femur, but never tibia again. So that is one dictum we must always follow, and we'll talk about it later. You put as few pins as possible. Now there are instruments available, the spoon, which can let you cut a little less if the defect is deeper than usual. Actually speaking, the amount of bone you remove from the medial side should almost look like the bone that we remove on the medial side in a varus total knee. So just underneath the surface of the defect. And if it is a deeper defect, as in severe deformities, we don't go under the defect, we go over and drill some holes in that, put cement. So that should be the philosophy, as little bone as possible in this. So there is a G clamp available. We'll let you aim for either a 3 millimeter or a 4 millimeter bearing, and that of course we can go. Again, important thing is that we should make the cuts in such a way that we do not cause damage to the posterior cortex. So our hand should always be dropping down, and we should try and lateralize it and cover the whole of medial tibial plateau. That's important. If we do not cover it, then it can sink and cause fracture. So these are very important. There should be almost 100% coverage of the cut surface. And then again, as I said, don't lift the hand, and we can change the mediolateral position of the component a little bit by recutting on the tibia on the medial or lateral side. So these are important. Starting hole is much different in uni knee. It's not in the middle of the notch, it's a bit medial in line with the lateral border of the medial femoral condyle, and this is where, and then there are different instruments available which let you put this jig in so that it will cut up in about 10-degree flexion, 7-degree valgus for the femur, and that's the way physiologically it is the best. So once we have done that, then we need to make the holes in the center of the medial femoral condyle, and these are various jigs that are available, very beautiful micro instruments, microplasty jig, the reamer is available, and that makes the surfaces very nice. Again, it's important that we determine the flexion extension gap nicely, because if we accidentally happen to have too much of extension and less flexion, then there is no bailout. So there's a very long learning curve with this. Every time we are doing this surgery, you have to be very, very careful. Don't go wrong. Don't cut the medial collateral ligament. Balance should be absolutely right. Otherwise, it will end up in disaster. We don't have to drill too many holes. So there is a formula of how to calculate. I will not obviously go into that. When we start doing it, we can always learn that. And then there is a very nice sophisticated instrument which takes away anteromedial part of the femur, and then that prevents impinging of patella onto the implant. This implant is actually sunk. That is why if there is medial arthritis, number one, it takes away that part, patellofemoral arthritis, and patella doesn't come in contact, and you can accept it and go ahead with a partial knee arthroplasty. A small little video, I don't know if it will work, and I'll cut it short if time is less. So it's the choice of the patient is very important. Extremely, I think the most important step in this surgery is choosing your patient right. The wrongly chosen patient has bad results. We can use a leg holder. I now don't use leg holder. I find it very cumbersome, especially in Indian patients. Some of them are very short, very fat, and that leg holder which the company gives is horrible for those patients. So I use a normal table, and we hang the leg by the side of the table. This is a spoon I was talking about, which will guide us the amount of bone to be removed. There are different thicknesses of spoon available, and we can then decide. And here, one more important point is that when we are trying to place the jig, do not make too many holes, because that is a reason why people can have fractures in the tibial plateau, intraoperative or post-operative. So generally either only one or one a little more lateral, and then this cut has to be in line with the movement of the leg. So aiming at anterior superior iliac spine, or feel the direction of the leg movement. And now you'll see this kind of a biscuit comes out, and then we measure it according to the opposite side of the tibial implant, because measuring it the opposite side. Here, making the drill hole, you can see in line with the lateral border of the medial tibial plateau, putting a small little intramedullary rod inside, then attaching the jig with it for femoral cutting, making the holes, and then it will go on. I think I will stop this video here, because this is quite technical, and when we start doing the surgery, one can sort of learn this. So suffice it to say that these very sophisticated microplasty instruments are now available with us, which let us do the surgery through a relatively small incision. And the mill that is available, again, let's show you the milling. But that mill is again fantastic instrument, and it sort of reams the bone into shape very, very elegantly. This is cutting the posterior one, and then now this is the milling I was talking about. Once we have milled, then we can do the trials and all that. So we very often are doing bilateral. If it is unilateral, we unilateral. If it is bilateral, I've sometimes, about 4 or 5 times, done total knee on one side and uni on the other side. as in the previous demonstration, Ashish was mentioning that I also, like him, question every time I do a total knee, why did I not do uni in this? So I have to answer to myself, why did I not do uni? But that's the way I think now, that I should be doing uni in every case if I can, because the results are so good, and because you save the bone, and there are all plus advantages in doing that. This is how the results are. This is just after about 4 weeks. And this is what we expect after unis. You can walk nicely without support, you can sit cross-legged, you can do light sports, and no problem sitting cross-legged, no problem praying the way you want to pray as your tradition is, and all these things can be done. And we mobilize sometimes the same evening, sometimes the next morning. In bilateral, usually the next morning. Patient usually goes home in 2 to 3 days. My aim is to send the patient home the same day, but with all the insurance and with all the insecurities in our patient, I still have not been able to do it, but that's my aim. If you see different studies, this published in UK, uni results have been a little more superior than total knee in comparable cases. There's been huge criticism in about 10 years ago. That's why it sort of went into a little bit of disrepute initially. The reason was that every Tom, Dick and Harry started doing unis. And people who are doing only 5 or 10 unis a year also were doing it, and that gave bad results. So there were studies carried out. The results of unis in the hands of people who are doing uni regularly are distinctly superior to those who are doing it occasionally. So the important learning point now, even the Oxford people will tell you, is that only those people should do uni whose uni volume is about 25% of the total volume of knee replacement they do. So you should be doing at least 25 unis, at least a year. That's the minimum. I mean, if you're doing more, obviously is better, but at least that. Only then one can start to get good results. And if you see in literature, there are 10-year survival rate more than 95%. It is not a temporary operation. It's as definitive a surgery as a total knee orthoplasty for osteoarthrosis. So all these myths which were there have to be laid to rest now, because it gives really good results, very good function, near normal gait, and the longevity is as good as the total knee, and we save the bone at the same time. Now, there was this article which is quoted very often, Cogin and Scott, that you can't do it in very active, you can't do it in obese, you cannot do it in that. But with mobile bearing, all these contraindications have gone out of the window, and you can do it even in obese people, you can do it in other people, because mobile bearing, it compensates so many things, and the results have been consistently good. Now, this lady is 103 kilo. I did, uni in her case. She is the wife of a Supreme Court lawyer practicing today, and if I did not believe in this procedure, I would not have done it in 103 kilo. And her results 3 years down the line were so good. Her husband, who's a lawyer in Supreme Court himself, came and he said, please do mine also, and he also got it done. So now this lady is now about 4 years down the line and doing very good results. Another scenario which is a little tricky is recurvatum with varus. Usually recurvatum is neurological in origin, but non-neurological recurvatum also exists, and in these cases there are 3 options: HTO, total knee arthroplasty, or a uni. HTO also has not given good results if you go into the literature. Total knee arthroplasty seems, I think, a little better in this scenario, because there are many factors you can control. You can put a smaller component, you can do more posterior release, you can cut less distal femur, you can cut less tibia. So there are many things. But can we do uni? We have done about 4 cases in recurvatum, and even the literature now says that the results are probably as good. But today, if you ask me if I'll choose uni for a recurvatum, I will not choose it for more than 5 to 10 degree recurvatum. Certainly not more than 10 degree. Up to 10 degree recurvatum with varus, I'll be game, but not more than that. And in that, of course, in uni also, we will mill less for the distal femur, so we maintain the extension space which was wider earlier on. So what can be the complications? The most dreaded complication is number 1, intraoperative tibial plateau fracture. So as I said, make as few holes as possible. and cover the whole of tibia, the cut surface. And that if you do this, even the late fractures will not happen. Bearing can dislocate. That will happen if we have accidentally damaged the medial collateral ligament or if our balancing was not right. As I said, this operation is technically challenging. It is not like total knee. It's not, you can't do it with your eyes closed. Even after having done more than 400, I still am a little bit tense when I'm doing it, till it finishes nicely and I have take a deep breath, yeah, it went on well. So it's something you have to be very, very careful about every step. Impingement, of course, can be avoided by placing your plate a little bit more laterally. So the take-home message is that anteromedial OA is a distinct entity. X-rays are sufficient to distinguish anteromedial OA from other types of OA. Mobile bearing partial knee is an excellent option for anteromedial OA, but we must remember strict criteria must apply to choose. Patient selection is more important than how to do the surgery. That I will like to emphasize and re-emphasize is very, very important. And overweight is not a contraindication, and many other contraindications of Coggin and Scott are no longer hold true. It's a demanding procedure, long learning curve, and it gives better results in the hands of surgeons who are doing it regularly. So please, if you want to take it up, anybody wants to take it up, please take it up on a regular basis. In fact, I believe so much in it that I did this bilateral for our BJP president last year. It's almost 1 year down the line. And we did it on 25th of August last year, and 17th September, which is Prime Minister's birthday, he walked up to PM House, climbed stairs and greeted him there. So the results can be so quick and the rehabilitation can be so quick. And then he went through all the UP elections after that. So these are fantastic results in uni. And these are some of the reference papers. And as luck would have it, this has appeared in today's Times of India, Delhi Times, how partial knee replacement is gaining popularity. I hope I have been able to cover it nicely. If there are any questions, I'll be happy to answer. Thank you for your attention.
Dr. Gulati, thank you so much and wonderfully articulated lecture. I just have one question with two parts to it. First part is there a cutoff of overall limb varus beyond which you do not contemplate a mobile bearing uni? And the second part is there a role for a HTO combined with a uni in certain cases?
There are a couple of papers in failed HTO where uni has been done, but I personally will not do it. What was the other one? Age cutoff?
No, overall alignment cutoff.
Yeah, I mean, for me it would be 15 degree, not more than 15 degree varus, and not more than 15 degree flexion and not more than 15 degree varus. In fact, even I would keep it a lesser side than bigger side.
Thank you, sir. My question is, as you said, the indication of choosing of a patient is more important than other things. So may I ask you to what is your criteria, either an X-ray or a CT scan or a clinical sense of thing, that you can choose the patient for unilateral surgery?
So number one, age is not a criteria as far as I'm concerned. I have done it for a 78-year-old man, a very well-known industrialist. In fact, he is the somebody of our neurosurgeon in our hospital, and he's done wonderfully well, and I've done it for a 45. So age is, to my mind, not a criteria. It's a type of problem. Weight also up to a limit. Of course, you're not going to do it beyond 35, 36 BMI. You know, up to a point, even weight is not a criteria. So for me, the criteria is a medial bone-on-bone arthritis. When you ask the patient, where is your pain? And I'm very intently looking what the patient is going to say and where the patient is going to put the hand. If the patient puts his or her hand on the medial aspect of the knee, meri dard yahan hai, that's it. Number one. Sometimes they put the hand anteriorly over patella also, but then I ask deeper question, is there pain medially and anterior? So that's one criteria. Second criteria again is the most important, is whether the arthritis is demonstrated bone on bone or not. And then on X-rays, whether the medial joint opens or not, whether the lateral joint collapses or not, and on the lateral view, is the defect going all the way back to the posterior tibial plateau or not. So if these criteria are met, then I'm game for partial knee.
One thing one thing I can ask, you can say the posterior part of the joint is intact, must be intact.
Yeah,
So-
that bump, we are looking for that bump.
Yeah. So how can you assess? Why are you X-ray or
Only X-ray, only lateral X-ray you can assess.
Okay, thanks.
Thank you so much, sir. Yeah, Dr. Vijay, one more question.
Dr. Gulati, for an excellent, rendition of a difficult topic. I would like to add to a comment on the how much virus you can do. So, in India, when you look at the patient, a lot of patients have a lot of tibia vara. So, apparently the virus is much higher. But we have done lots and lots of cases in these, and Dr. Yash must have also done it. The more important is the intra-articular varus, right? The intra-articular varus should not be more than 15 degrees. And why it said 15 degrees is that when your intra-articular varus becomes more than 15-20 degrees, your MCL starts getting contracted, right? So your MCL should not be contracted. If your MCL is contracted, then you cannot do a mobile bearing uni. I'm not, a fixed bearing maybe still, but a mobile bearing uni would not work on, it's not a good indication to do it. But if you take a scanogram and if you see the whole varus, sometimes they are almost 20, 25, the line is dead center, but you can still do them. The intra-articular varus should not be more than 15. Other thing is it should be correctable varus on a lateral, on a varus valgus stress view. In a valgus stress view, if your medial joint space opening is around 4 mm, right? And there is no compression on the lateral, on the lateral side. That means your MCL is not contracted and you can safely do a uni.
Yeah,
A
Vijay,
mobile bearing
I
Oxford
absolutely agree with you. This is a very important point you have made, and that the varus has to be correctable. That medial space should open on valgus stress, as we showed on the X-ray also. If it doesn't open, that means the medial collateral ligament is contracted. That's very important point.
Yes, sir. And as you rightly said, mobile bearing has its own inherent advantages of no point loading. So even when you put a mobile bearing implant, even if you have a greater degree of varus and it's correctable, it's quite forgiving at the end of the day, as long as the bone quality where your tibial base plate sits is good enough.
Yeah, I mean, see, the dreaded complication is the tibial plateau fracture. So we have to be very careful, very, be paranoid about it. Absolute paranoid. That is, don't end up having that. Absolute paranoid.
Thank you so much, sir. If I can invite our next speaker,
Thank you, Chairman.
Thank you so much.
Thank you very much indeed.
Dr. Jayant Arora, who's going to be talking to us about certain inherent challenges that we have in our Indian patients, that do they really